today, my focus is on how Bill 30 supports the government's aim to consolidate authority, primarily in the minister and in the health ministry, for what I think is, either supporting their privatization agenda, so the agenda to increase corporatization and privatization of delivery in Alberta, or viewed from a different perspective, to have some measure of control over any opposition to that agenda. So you can either look at it as if it's a purposeful consolidation for the purposes of making sure that their plans go according to the way they want it, or to ease resistance to it. Now, I should note, as I noted at the beginning of the last presentation, much of what I'm going to tell you today is really my take on what these amendments are doing, but I'm going to try and stay very true to what the amendments actually do provide, while injecting a bit of informed speculation on where I think this is going. It's also important to understand that there really isn't anything unusual about the government trying to revise legislation to achieve its policy agenda. But the criticisms that I'm going to offer today really relate to what I believe things that are not evidence-based or will not serve the healthcare system in a beneficial way. So that's what today's going to be about, talking about how the government is centralizing and consolidating authority in the minister's office for a privatization and corporatization agenda. I wanted to start off by just first taking a moment to honor Dr. Walter Reynolds. I really wanted to sort of, just take a moment to, shut up and have us sort of reflect on what this so terrible incident means, and just to honor him. I'm going to dedicate this talk to him. So I will shut up for about 30 seconds to allow that. Thank you for indulging that. And really my condolences go out to his family, friends, and of course, all of you who are his colleagues, and for those of you who know him. Again, it's a very terrible incident, and I know what can bring about any kind of measure of relief here, but my condolences. Okay, so back to the talk. My focus today will be on Bill 30 amendments to 3 statutes, including the Health Professions Act, the Health Quality Council of Alberta Act, and a change to the Regional Health Authorities Act that has not been addressed much. And I think these changes, taken as a whole, suggest that the government is purposefully trying to centralize authority in the minister's office. And that's where that's where I'm going to sort of keep hitting at. That's my focus, is to address what these changes are that suggest this consolidation or centralization of authority in what used to be a framework where authority was given to either self-regulating bodies or to independent bodies to really provide healthcare services or handle aspects of our system and operate those aspects of our system that the government and the minister's office in particular is, in my opinion, not well equipped to deal with. So where you have the minister taking from, through this legislation, from people who are better equipped or institutions that are better equipped to deal with this, that raises red flags for me, and I'm going to address what those red flags are. I will spend no more than a couple of minutes on the proposals to amend the Health Professions Act to improve what the government calls regulatory effectiveness and efficiency, that discussion paper that I'm sure many of you have seen now. It's a massive document, so I'm not going to be spending time going through all of it. And indeed, it's not really the focus of today's presentation. But I do have some things I'd like to point out there that I think add to this whole story of centralization. So I've only picked some of the proposals that I think add to the story of centralization, and I will address them at the end of the talk. So first, the Health Professions Act. Now, I'm sure everyone listening to this is familiar with what the Health Professions Act does, but for those of you who, and I don't know if there's some people who are not doctors who have joined this webinar, so I will just go over very quickly what the Health Professions Act does. In Alberta, we have one legislation, the Health Professions Act, which sets out a common approach to governance of all health professions. Now, this is different from what obtains in some other provinces where they have specific legislation for each profession. This is one model of regulation of professions where you have just one statute that sets out a common approach for governance of all health professions. So as you might expect, this umbrella legislation sets out the big picture of how each health profession should organize itself. It's a common approach. And then for profession-specific rules, you have to go to regulations that are made pursuant to this legislation. And of course, to specific professional rules, codes, and standards. So the CPSA, of course, is governed by the Health Professions Act, and in fact, created through the Health Professions Act, but it also has its own set of regulations. So the medical profession has its own set of regulations. And of course, the CPSA makes rules and codes and standards that are pursuant to this legislation, which apply to the medical profession specifically. The Health Professions Act also creates the regulatory structure for what you all know as self-regulation, which is this idea that each profession is best equipped to regulate itself. And so the Health Professions Act gives power to the professions to regulate themselves and to set up colleges to do so. Now, this is an idea that's actually a very good one, given the fact that professions are made up of people who have technical expertise and who have the best understanding of how they should be governed and of what their standards should be. I think it makes sense for the government to say, we're not going to play the middle person here. We're not going to get involved in something we don't know about. So instead, we're going to enable you to regulate yourself. But it's important that you do so in a way that protects the public interest. And the idea behind the Health Professions Act is to set out what the scope of that public interest should be, and then allow the colleges to do their thing. Now, one thing about the Health Professions Act is that because it applies to every profession, the changes that are made to it inevitably affect every profession. And so you might look at these changes in Bill 30 and go, well, that doesn't make any sense for the CPSA. But that's because the Health Professions Act cannot be amended specifically for the CPSA. It is amended for every profession. And that, I think, could sometimes lead to amendments that may not make sense from the perspective of one profession, but do for others, especially the smaller colleges. And I think that's very relevant to what we're going to be talking about today. Now, the colleges, as you know, implement essentially two kinds of regulation, again, pursuant to the Health Professions Act. They deal with what we call input regulation, which is that they control entry into the profession. So registration, in the case of the CPSA, to practice, as well as output regulation, which involves two things: making sure that providers or members remain competent, and also dealing with discipline of members. Now, Bill 30 does make changes to the Health Professions Act. Those changes are quite minor, really at this stage, nothing too significant. And this is really the main change that it makes to the Health Professions Act, and it's quite minor. Essentially, Bill 30 says that on council, on the CPS, on the council of every college, on the complaints review committee and the hearing tribunal. So the regulatory and the discipline side of things, in fact, all the functions are affected in terms of participation of members in these bodies, or any panel of them must be made up of public members that amount to 50% of the voting members. So this change is actually, in theory, a good thing. I think the change could theoretically enhance the self-regulatory process by adding more diverse voices on these bodies and improving public trust. I think the bargain of self-regulation is that if we're going to allow the professions to regulate themselves, then we have to have a measure of confidence in them protecting the public interest. And we have to assure that by making sure that public interest is well represented and well accounted for. And I think the colleges would, in fact, including the CPSA, would in fact welcome this change. And in fact, from what I've read and from the reactions I've seen from the CPSA, they do welcome this change. So it's, in theory, a good change. I do have some reservations about it, which I'll note very quickly. So as I've said, the change will add diversity, increase public input, and improve public trust. However, given that it's happening now in the current context of what's going on between the government and physicians, it does raise questions for me. And two questions in particular. The first is, I do think this government has a tendency towards cronyism, and questions arise as to whether they will actually find public members who represent the public interest or represent instead the government's political interests, which may not necessarily be aligned with the public interest. I think that is a question for me. And so we know the government is engaged in this increased privatization of public healthcare delivery. We know it's controversial. And so one wonders if this is an attempt to increase control over, in order to further that privatization agenda. Now, why would they want to increase control or increase representation in the CPSA to do this? Because the CPSA actually plays a role in private delivery as contemplated under the changes in Bill 30. Two things that the CPSA will do under Bill 30. The first is they are responsible for accrediting the private surgical facilities.
We lost you there, Dr. Ogbogu.
Or as skeptical as I am, you might think, so the government is, this might be an attempt to put people on council to make sure that this role is something that they have a measure of control over, or that at least they exert influence over the CPSA role in private delivery. Okay, so that's really all for the Health Professions Act. I don't think these changes are major changes, but I do have questions around the increase in public members, simply because I have questions about how the government is going about this. Now, let's turn to the HQCA, where I think they've actually made major changes and changes that are quite substantial. Now, why would the government concern itself with trying to change how the HQCA operates? I think to be able to understand why the government would be interested in HQCA, it's important to understand what the HQCA does. And so I'm going to spend about 5 to 10 minutes telling you about what the HQCA does. So the HQCA has a very long history. going back to early 2000s, and even earlier than that. It used to be known as something else, and in 2011, a statute was enacted, which brought it into focus and made it its own thing, and then gave it a mandate to do certain things within our healthcare system. The best way to think of the HQCA is that it is one of the three major players in our healthcare system. So you have the ministry, you have AHS, the single health authority, and then you have the HQCA. And the HQCA stands on its own and has an important function within the healthcare system. The HQCA was established by the HQCA Act of 2011, and it is an independent statutory corporation. So it's a corporation that's created by statute to be independent and at arm's length from government. It can work with government, but it's at arm's length from government. It has its own mandate and it has its own responsibilities. And even though it is required to network and cooperate with other government agencies in the healthcare system, it stands on its own. Its primary mandate is to promote patient safety and health service quality on a province-wide basis. This, many of you will recognize right off the bat as a very important function. Patient safety is very important, and health service quality, of course, is undeniably important. And so the HQCA stands apart from the other agencies within the system and provides this function. So you can understand that if you have a ministry that's setting policy for how healthcare should operate, then you have a provider in AHS, you need an independent body to sort of scrutinize what these two other components of our healthcare system, these two institutions in our healthcare system, what they do, and to do that independently for the sake of safeguarding health service quality and patient safety, or at least providing information about how these two things can operate optimally for the benefit of both patients, providers, and those who operate the system. Here's a list of all the things that HQCA does. This is a list of its primary mandate in the legislation before the legislation was changed recently. I am not going to go through all of this, but I want to highlight the very first one. That is actually really important. Its function prior to the Bill 30 changes, its main function was to measure, monitor, and assess patient safety and health service quality, and to do so independently, and to generate information which is then fed back into the system to help improve patient safety and health service quality. This is undeniably something that all of us should care about. And we, of course, want an independent body to do this. So I like to, when I talk about HQCA, I like to sort of compare this to the role of the Auditor General. You need an independent body to provide a level of independent examination, scrutiny, and oversight or evaluation of how our system is performing, and be able to provide information back to every stakeholder about how the system is functioning. And that's where the HQCA really comes in. It's a really important body. Its footprint in our province is huge, even though its visibility sometimes doesn't seem as, it doesn't take up as much space as the ministry and AHS. Now, many of you will be familiar with the products of the HQCA, and I'm sure you've used the products. I'm going to go through this very quickly. I'm sure you've heard of the Health Quality Matrix. That's a product of the HQCA working in collaboration with its stakeholders, including physicians and primary care providers in the province. I'm sure you've also heard of and probably used the panel reports, which I think is one of the HQCA's most significant products. This gives physicians and those in primary care a window into how the services they provide are operating from the patient perspective. And it provides a tool for them to use in program planning, panel management, and quality improvement. I know many of you have used the panel reports from the HQCA. If you go to the HQCA website, you'll see that they've organized their products along the lines of resources for healthcare providers, studies and reviews, and all kinds of surveys that they do of Albertans. So for example, they have a survey right now where they're surveying Albertans about the experiences with the healthcare system during COVID-19, which will be very valuable information for all stakeholders in the system to understand how healthcare worked during the COVID-19 crisis. And here's a long list. They've done surveys in long-term care, all kinds of things that the HQCA has done that really support patient care. I had some videos here, but for some reason, they're not showing up on the Zoom screen sharing. But I encourage you to go to YouTube, search for HQCA. They have a channel on YouTube, and then they have videos that explain everything that they do. This is really an organization that is small but powerful. It's one of the highlights of my career has been to be involved with this organization, which is regarded even among quality councils in the world as the leading quality council. And the two things that people say when they comment about the HQCA and about how it's a leader in the world is that it's independent from government, so it's able to generate this information without political interference, but also that it is an organization that operates and produces a lot of information that serves as guidance for other quality councils while working on what is really a shoestring budget. It is really a remarkable organization. Okay, so that's what the HQCA does. I'm sure you've heard about Focus on Healthcare as well. I won't play the video. These slides will be available, so you can, or maybe I should. I'll just give you a quick sense of what Focus is about. Can you hear it? Is there volume? Never, I'll just skip it. I'll provide the slides later so you can look at what it is. But Focus is a new product from the HQCA that I think you should all check out if you haven't checked it out already. That gives you really a system-wide overview of how our system is performing on different measures. Okay, I will skip ahead. Now, HQCA also has a governance framework that is set by the HQCA Act. I will quickly explain what our governance framework looks like prior to Bill 30, pre-Bill 30. So the HQCA is governed really, so the policy setting body for the HQCA is the board of directors. And the board of directors, I was a member of the board of directors, is appointed or was appointed by the Lieutenant Governor in Council. Again, this speaks to the HQCA's independence. It is not appointed by the minister. It's the Lieutenant Governor in Council that appoints the HQCA. Now, in practice, obviously, the ministry and the minister have a role in identifying who the members of the board of directors are and in putting them forward for appointment. But this is an important separation from the ministry. When I was appointed to the board, even though I was identified and interviewed by the ministry, my appointment came from the Lieutenant Governor, and I was made to understand that I am serving the people of Alberta, not any political party or the interest of the political party represented by the minister. I was serving Albertans directly, and the independence was a key part of that. The board has very diverse expertise. Again, it's a really remarkable organization. When I worked on it, there were experts drawn from every field that you really need for a health quality council, people in quality improvement, doctors, lawyers, nurses, really remarkable organization, patient safety experts, diverse expertise. And the board submits its annual report to the Legislative Assembly, again, to try and sort of circumvent political interference or avoid that. The board doesn't report to the minister and doesn't receive directions from the minister. The minister can ask it to do, can commission it to do work, but its primary mandate comes directly from legislation, and it reports to the Legislative Assembly on what it's done. Now, what did Bill 30 do to the HQCA? Bill 30 repealed or changed, that's supposed to be, sorry, it's repealed or change of foundational elements of its independence and mandate. So Bill 30 really cuts deep. Bill 30 takes away the foundational elements of its independence and its mandate. And I'll explain how that happened. So I told you that its main mandate is to measure, monitor, and assess patient safety and health service quality. This really is the bedrock of what it does. HQCA recruits staff who are some of the best experts we have in the province in how to measure, monitor, and assess patient safety and health service quality. You know, statisticians of high quality and extensive training, people who are skilled to produce kind of products that I've just shown you, who are able to take a system-wide view and able to sort of analyze the system in a way that leads to recommendations for quality improvement and patient safety. Bill 30 takes that and throws it in the bin and replaces it with language that says that the HQCA is now to assist in information gathering, program assessment, and knowledge exchange. Doesn't really say who the HQCA is assisting, but what's important is that function is gone. Its main function is gone, is now assisting. And so the language indicates that it's assisting the minister's office, which is really problematic since the minister's office is not well equipped to generate the kind of information that triggers the kind of work that HQCA does. And if the minister is generating that, you can expect that will be politically generated measures that are sent into the HQCA. So the HQCA is basically doing the ministry's bidding or the minister's bidding, as opposed to asking itself, what about the system do we need to measure? Who do we need to work with? It's no longer independent. It's now going to do things to assist instead of generating on its own recognizance what it ought to be doing. The board is now to be appointed by the minister instead of the lieutenant governor and council. The HQCA is to report to the minister instead of the legislative assembly. And this one actually is, I think, a shame. The HQCA is no longer to survey Albertans. So the language in the previous legislation was HQCA surveys Albertans about their experience and their satisfaction with the system. They could do this on their own. That has not been replaced with language that says that HQCA should engage with Albertans, which is kind of vague. What does that mean? Does it still allow them to survey? Well, I don't think so, because if the survey language was not a problem, why repeal it and replace it with engage with Albertans? So this seems like talk to Albertans, but please don't do surveys anymore. Work cannot be assigned to council by ministerial directive. So the HQCA can now get a directive from the minister as to what he should be focusing on. And of course, the minister can, by directive, say, don't focus on that. So that I think it's quite fundamental. Another change is that the deputy minister or a delegate of deputy minister now has, HQCA is required to send notice of every meeting of the board to the deputy minister, and a deputy minister or a delegate of the minister is now allowed by the statute to attend all meetings of the board. This, I think, is a massive problem. Obviously, if you have the government in the room, the HQCA cannot be viewed as independent. And, you know, if the deputy minister is in the room, the board cannot transact business. This is a massive conflict for the government. It cannot transact business that is against the government's interest. The statute, Bill 30 replaces submit any reports and advice to the minister. So it used to be that the HQCA could decide what reports to send to the minister, or could come up with recommendations for system improvement and send it to the minister to advise the minister on ways to improve the system. Now, that language has been replaced with submit any records or other information to the minister. This is in fact terrible. Why? Because the HQCA receives information from third-party stakeholders. And the last thing you want is for the government to say, give us what the CPSA gave you, or give us what that doctor over there gave you. That is not a good thing, because even if people see this, they don't want to trust the HQCA with information. because that information could end up in the hands of the minister, and the minister now has power to request that information and to receive it. There were provisions in the statute that allowed the HQCA to network with physicians, with other stakeholders in the system. Those provisions have been straight up repealed. No more networking. You now do what we tell you to do, and we don't want you collaborating or networking with other agencies. So last week, people asked me why I resigned from the HQCA. I think it should be clear by now that why I resigned. But let me spend a couple of minutes talking about that. In my time in the HQCA, and this goes back really to the NDP government, one of the struggles that I had on the board was that it was really I felt personally, and I'm not speaking on behalf of the board, obviously, that it was difficult to get the government to work as a partner. And when I say the government, I mean sort of the ministry, the Minister of Health, to work as a partner with the HQCA. There were always, sort of this suspicion that the HQCA was working against the government, which again sort of explains why it has to be independent. Because I think governments don't like to be measured and monitored unless they're doing it themselves. And there was always this sort of, we're kind of suspicious of what the HQCA is doing. Now with this government, what I noticed was really discourtesy in the way they dealt with the HQCA. So they will take actions without any consultation with the HQCA. They take actions without any consultation with the HQCA. They will surprise us with announcements without any warning. They will do things without giving any heads up or without asking for input into what they were doing. These changes to Bill 30, as a board member, I learned about after they were announced. There was no heads up, and I think that's this kind of discourtesy. I don't like working in a system where you're supposed to have a partner, but what you have is uncertainty and just sort of lack of basic respect. So that was part of the reason why I resigned. The lack of consultation, really set me off as well. But I think the biggest reason was for me was, if it's not broken, why fix it? This is a quality council that's regarded as the best in the world, not even one of the best, it's the best in the world. The government's rationale, as expressed in statements that they put out, was that they wanted to align, to make the HQCA resemble other health quality councils elsewhere that were essentially under the control of government. That to me is quite ridiculous. You don't lower your standards so you can align with others. If we're the best, they should look up to us. We shouldn't be looking up to people who look up to us. It makes no sense to fix a system that is regarded as the best. But also because this was flying under the radar, given that Bill 30 was an omnibus legislation that had all these changes going on, people were not really understanding that the government was trying to bring an organization that is so important to Albertans under its control. And so I resigned to highlight this and to bring it into focus for Albertans so they can understand what's going on here. Okay, lastly, the Regional Health Authorities Act. So, but before I get into this, so my point is that these changes, as you can see, really take away the HQCA's independence and changes its mandate. Why would the government be doing that? Again, I think if there's one organization that can shine a light on how the government's proposals for privatization and corporatization are working, it'll have to be the HQCA. The HQCA measures and monitors the system. And if the HQCA is studying how private delivery is working, I don't think the government wants them to be doing that without any form of control. The government is putting out something that is new into the world, that is newish. And I think the last thing they want is to have a body that is looking at how these additions and these changes are impacting the system. And I think they worry that the HQCA, the information that the HQCA produces, the surveys that they do, the measuring that they do, will shine a light on this, and they have no control because the HQCA puts out that product. They do consult with the minister before they put out a product, but they put out that product in the way that they've produced it, pure evidence-based information. They put that out to the world, and I don't think the minister wants that. So this is an attempt to bring it under its control in a way that changes its mandate so that it's not able to monitor the system anymore, but also that robs it of its independence to be able to work on its own, to generate these outputs that help our system improve. Now, lastly, this under the radar amendment in the Regional Health Authorities Act is also, I think, very relevant. Now, the Regional Health Authorities Act, of course, is the statute that sets out the authority and responsibilities of Alberta Health Services, which is our single health authority in the province. We used to be that we had several regional health authorities that were now amalgamated, and we now have a single one called Alberta Health Services, which you're all familiar with. Now, under the Regional Health Authorities Act, prior to Bill 30, AHS had final authority over all of these things that I've listed here, over promoting and protecting the population's health, assessing health needs, determining service priorities, and allocating resources accordingly, and ensuring access. So in essence, AHS had final authority to decide operational matters and service priorities in our healthcare system. On that, changes to Bill 30, and this has flown under the radar. AHS no longer has final authority over these things. These things have been repatriated. Well, not repatriated, have been taken over by the minister's office, by the minister. So what you now find is that all of these responsibilities have been downgraded to purposes that the AHS has to fulfill in the planning and delivery of health services. They no longer have primary responsibility for these things. Instead, the only responsibilities that remain are to plan and deliver health services. And in doing so, they have to consider these purposes as opposed to having final authority over them. So the minister can certainly dictate these purposes to them in the plan and delivery of health services. This, I think, should get more play than it gets. As we've seen in the recent reveal by CBC of what's going on with, of those meetings that involved lobbyists, surgeons, orthopedic surgeons, and government officials. If you read that story, you see an attempt to shut out AHS from these discussions. It used to be the case that AHS would be the contracting party with the surgeons. But it's not clear now what AHS's role is going to be in the new arrangement with these private surgical facilities or these charter surgical facilities. And in taking over these responsibilities from AHS, and now that we're starting to see information that suggests that AHS is going to be shut out of the conversation, one wonders how that's going to play out when these things start to roll out. Another change is that AHS is now subject to accountability frameworks that are established by ministerial order. This is also new. I really think this should get more play. As a matter of fact, my colleague Lorianne Hardcastle and I have written a commentary on this that is due out in a matter of days, but we're also thinking of developing it into an academic paper where we sort of examine where this is going. But I think it's something to watch out for sure. Now, to close, a few thoughts on the discussion paper. So there's a lot to dig into in the discussion paper, but I will say that overall, I don't want to spend too much time on this since it's not really done yet, but I should say that overall, it's important to note that the proposals put forward suggest different options. In general, any option that is geared towards centralization should be viewed a little bit more closely than the ones that allow professions to do what they do. Now, this is where that problem that I noticed at the beginning comes up. Because we have an umbrella legislation that applies to all the professions, these changes, I think, are necessary for some of these options are necessary for some professions compared to others. If you centralize authority, it may be a good thing for colleges that are not meeting the standards they should meet in terms of those options and the public interest. But it may put colleges that are doing what they're supposed to do at a disadvantage because they now are subject to this centralization when they are actually the model to copy. So what I mean by that is if say, for example, the CPSC is doing something the right way and the College of Naturopaths is not doing something the right way, centralization might benefit the public interest in relation to the naturopaths, but not physicians and surgeons who are doing what you expect them to do in terms of the public interest. So that's sort of a big picture way to view this discussion paper is if we're already doing something that we think is great, why will centralization take something away from us when it's not our problem, really? It's not an issue for us. And instead, should we be going for options that preserve our independence from government and suggesting that the government instead focus on bringing colleges that are behind up to speed. So let me very quickly address three proposals. The first is proposal number 4, which says to enable a centralized registry of health professionals in Alberta. So there are two options under this proposal. The first is to establish a centralized health professional registry that will be maintained on the government website. The registry would include member information from all colleges. So this might be a good thing, if you have some colleges who are not very transparent in terms of what kinds of members they register. But colleges have vastly different levels of transparency when it comes to different things that they deal with, such as, for example, the results of disciplinary decisions. Now, some colleges do it better than others. So I think it might be better to say, instead of saying let's centralize a registry for how these things operate, why not just have the colleges who don't do it as well emulate the ones that do it very well? The second option says government would oversee the registration of health professionals and responsibility for professional registration conducted by a single agency established by government. I'm not going to comment too much on this, so it won't seem as if I'm giving any kind of advice on this, but this to my mind personally is a terrible idea. I don't think government is any better equipped to do this than the colleges are. And in fact, I think this might end up being a dangerous thing depending on how they do it. Because it's not likely the government is going to serve merely an administrative function of registering health professionals. So they're not going to be doing just the paperwork, fees, and all whatnot. They're not going to do that. I think maybe what they might do is actually decide who gets in and who gets out. So they'll be doing the input regulation that I described at the beginning. And I think that would be, for me, a very concerning development. Because, on the one hand, the government is not very well equipped to do this in a technical sense, but also, who knows who they're going to let in, especially given that they have this agenda and given their current relationship with physicians. They might come up with inventive ways to fill the gaps created by the loss of physicians in the province. Okay. Proposal number 5, revise the current professional complaints and disciplines process. They have several options here. Again, let me just say, very quickly, I'm actually somebody who thinks that a lot needs to be done in the area of how colleges discipline their members. I will say this, that I think the college in the past few years has sort of tightened this up. The College of Physicians and Surgeons especially has tightened this up in response to criticisms about how discipline occurs. I have my worries about the system of discipline and whether it protects public interest. And I don't think this will be news to anybody who is part of the CPSA. I think this is one area where the college needs to really look inward and tighten things up before the government does it for them. I really do think that this should rest with the colleges. They're in the best position to do this. But we've seen instances, and for the most part, it's possible that college is doing this right, but we've seen instances where questions have arisen as to whether or not the college has represented the public interest in terms of discipline when it comes to members of the profession. And so I think, it's good to tighten those things up before the government takes over, because if they do, and one of the options here express that they might, if they do, I don't think the college is going to like it. I am very concerned about the option where there's too much government control, because there'll be loss of expertise. Government clearly has a conflict of interest, because there might be situations involving the government. The discipline might actually involve the government. And so, that's all I'm going to say for this. It's look inward, tighten things up, because any option that tends towards centralization is not going to be good. It's not going to be good for the profession. And then lastly, proposal number 12, which says to provide for the approval of professional regulations by the minister rather than Lieutenant Governing Council. I think, to be honest, this is probably what happens in practice. But again, this is one of those things where, there's a reason for making the change. And it worries me that the change is being made explicit. This is being made explicit in legislation, even though I think this is what maybe happens practically. I think, again, this is concerning because I do question the current government's motives in trying to take over the process of approval of professional regulations, and what that might do to the kind of regulations that we see. I think when a profession has decided how it's going to regulate itself, I think the minister really should be endorsing that. So long as the profession seeks appropriate public input and represents public interest. That's not to say that changes will not happen, but I am concerned about this change because I see it as similar to the change with the HQCA, and I see sort of echoes of it in the changes to the Health Professions Act. And I think all of this show a trend towards moving things towards the minister's office. So why is the minister interested in taking over all of this? A minister's role really is to set sort of high-level priorities and make sure that those priorities are reflected. The government's priorities are reflected in the way the healthcare system functions. And what I'm seeing is sort of the minister moving into operational aspects of the system. And that to me is really the key message here. The dangerous thing here is that these legislative changes enable a worrying distance between the health services that our Albertans receive and those with the know-how to provide it, right? And that distance is now being occupied by the minister and the ministry who I think are the least equipped to actually deliver services or operationalize the system. And that to me is a concern. Now, maybe this is so that they can push forward the privatization agenda without any resistance. But these are changes being made in legislation, and legislative changes are enduring. They don't just go away. And so, it worries me that the minister is actually not doing this in a way that says, let me talk to you, let me work with you to try and figure out a way to achieve our aims. Instead, they are sort of using legislation to bulldoze their way into operational aspects. And that to me is quite concerning. Okay, that's all I have to say. Thank you for listening.